How's everybody? My name is Amy Jaramillo. I think I know a lot of you that are on this call, but there may be a number of folks that I don't. I am the scientific director here at BodyScience in South Miami. We treat a number of things, but our primary focus, our primary passion is motor neuron disease. And that's what we'll be talking about today. And so I'd like to just give another quick minute. And the reason we already have a number of people on board, I think over 40. But because we have a handful of additional registered, what I'm going to do is I'm going to give it 2 minutes and then I'm going to come right back. Okay, so don't go anywhere. I will be right back and then we'll get started. Okay, I'm back. Listen, let's get started. Again, I already went through the introduction, so you guys know me. I'm Amy. I am going to open a slide deck. For anybody that's seen me before, you know my style. I don't like to inundate with a lot of slides. Instead, my objective today is to give you an idea of some of the things that we're seeing over here as we're working with motor neuron disease and some of the issues we find more commonly in people that are coming on over, and some of the treatment strategies that we're using to address those things. So always when I'm on a webinar, I'm trying to do a couple of things. Number one, provide some of the more up-to-date information and research. And then number two, some tips that you can introduce into your own day-to-day, whether they're medications or lifestyle changes like diet related. And so let's get started. Let me go ahead and share my screen. And here we go. All right, so again, I'm Amy. I'm the scientific director here at BodyScience. Okay, so in the world of possibly the ugliest slides ever, I can imagine, must think sometimes, do I work hard to make slides that are this impressively ugly? I do not. It just seems to happen. Let me tell you what I'd like to do. The two categories, infections at the top, serotonin and dopamine at the bottom. I want to go through those two categories. I think that they are the most important for us to discuss today. With that in mind, I'm going to use this slide to have just kind of a general conversation about the category of infections. And then I'm going to go to the bottom part, which is really a serotonin dopamine related conversation as far as motor neuron survival, and the role that we look to continue to confirm with those neurotransmitters and speech and swallowing. So on this slide, again, let's talk about the first part. The reason I'm not going to do a lot of different slides, a number of you have heard me talking about infections before, and so I'd like to use these bullet points, but again, have kind of an open dialogue about them. I would tell you back in 2021, we started looking for tick-borne infections and didn't have a clear understanding prior to that of how prevalent tick-borne infections and co-infections, so Lyme and co-infections, were in motor neuron disease. The interesting thing, we treated a lot of those infections, would see improvements, but for limited periods of time. And it wasn't until articles started to come out describing the role of the herpes family of viruses in neuroinflammation that we were able to put more of the pieces together, understanding that primary or master infections, COVID, Lyme as two primary examples, oftentimes alter the immune system, and commonly by destroying or damaging T cells. Here's my point. It allows opportunistic infections, and very commonly what we're seeing is herpes infections, to then reactivate more commonly. Here's what we think we know as a center. Frequent reactivation of herpes viruses ultimately lead to neuroinflammation and neurodegeneration. There's been a lot of data, so I don't think there has ever been a time that I can recall where there was a worldwide pandemic infection that destroyed T cells in a way that we could really look at opportunistic infections coming out and seeing those symptoms. I think about late 80s, early 90s with HIV virus. That's probably the other one that comes to my mind. But COVID was interesting, right? In the fact that there were so many people that were infected with COVID. COVID is something as an infection that damages or destroys T cells. It's just one part of your immune system. But here's the question. If you destroy the part of the immune system that is vigilantly watching and keeping infections under control and is responsible for a number of infections, but has a very definite antiviral ability, and you destroy those T cells, what would you expect is going to happen with viruses that that person already has, but are essentially dormant? And the answer that we know now is they become active and disease causing, or lytic. We know it because after COVID, there looks to be this very widespread occurrence of herpes symptoms. It's not expected that these are people that were exposed to herpes for the first time, but rather reactivation. So let's say, for example, if for me, I had herpes simplex 1. Now, about 40% of people get cold sores, and the other 60% are totally asymptomatic. Let's say I had herpes simplex 2 or genital sores. Kind of the same thing. Lots of people are never symptomatic. Let's say I had a history of Epstein-Barr. So that is mononucleosis or kissing sickness. Let's say I have cytomegalovirus. Over 90% of the human population does. So we're still in the world of herpes. Let's say we're talking about herpes simplex 6, which has very definitely been associated with ALS. I may not know that I have any of those infections. I may never have had problems or symptoms. But after COVID, and for a number of people after the COVID vaccine, they started showing symptoms. Shingles as well, like the number of shingles outbreaks or cases over the last couple of years looks to be very high and is being attributed largely, not exclusively, but largely to the fact that if COVID can destroy T cells, which it does. So now remember, it's an army that is watching to control the infections that we all have. But those infections typically, because the immune system is always on high alert to keep them in a dormant state, they are limited to what they can do as far as disease causing. But you destroy enough T cells, usually with a master infection, Lyme or COVID, and all of a sudden you can release these things. Okay, it's hard to imagine, but I am still on point number 1. All right, so let me see if I can't move forward. All right, a couple of things for you. Going back to the fact that we treated Lyme and then we could see improvements, meaning functional gains. Right. So somebody that couldn't do something and now regains a function, but we couldn't maintain it. And that's when we realized it's not Lyme, it's not COVID, it's these underlying opportunistic infections, sometimes things like mycoplasma, so mycoplasmic pneumonia, Coxsackie, toxoplasma, and all of those have been associated with motor neuron damage, but more commonly the family of herpes viruses. Okay, so the couple things. Thing number 1, we were testing for antibodies to herpes at that point. Now we are very, very tuned into it. Thing number 2, zoster. So varicella zoster is a herpes infection that is rarely tested for. Here's the reason. It is associated with chickenpox or, in adults, shingles. The way that this has always looked in the past, if somebody has shingles, then they've got zoster. If they don't have shingles, then you probably don't have to worry that zoster is a problem, meaning it's not reactivating and causing disease. What we know here is that zoster oftentimes looks to reactivate. Again, you're triggering neuroinflammation and the resulting neurodegeneration, not just in zoster, but in the other herpes families. And so we started getting zoster testing. So starting first with antibodies, zoster is not on most labs. The reason, unless you ask for it specifically, the reason is because a lot of labs expect that if the clinician is looking for shingles, they're going to just order varicella zoster. But what we are finding is just like the other herpes viruses that may appear dormant. So in other words, I may not have a cold sore, but I could still have herpes simplex 1 reactivating and triggering disease. And if that reactivation is causing neuroinflammation, which it routinely does, then it can trigger neurodegeneration. And remember, the primary studies that have been done on that are looking at Epstein-Barr, which is one of the herpes family viruses, and it's linked to multiple sclerosis. So we know that these infections can confuse the immune system and cause the immune system, so your own immune system, to go after tissues in the brain and spinal cord. We know that they can cause all kinds of damage on cranial nerves, right? So the things that innervate the face and allow for speaking throughout the spine. We know that if these infections are at the base of the spine, herpes simplex 2, for example, and zoster as well, then you would commonly expect more symptoms in legs, pelvic girdle. If it's in the very lowest part of the spine, then you might expect to see somebody that has sciatica first, and then foot drop as one of their first presentations of motor neuron disease. If we're looking more at herpes simplex 1, you might expect that the presentation would be more upper body and specifically arms, shoulders, neck. Prior to motor neuron disease, you might expect that somebody would have just constant neck aches or shoulder aches, a handful of fasciculations occasionally in the arms. And so again, one of the things that we've done, we've added varicella zoster, or the shingles version of herpes virus, into the list of things that we look for. The reason, again, I'm telling you that is because it's commonly overlooked. We are always looking at Lyme infections and co-infections. Remember, that's the master switch. And then that second bullet point, until recently, we were just looking at antibodies. So antibodies, and that's the way most labs test for these infections. So the question is, are you making antibodies, and to which infections? The thinking is, if you're making antibodies, then that infection is active or causing problems. The question that we've continued to have is whether or not we're looking at autoantibody or immune confusion. So if we think that that lab is determining the target, high levels of antibodies to an infection. Now, remember, what you're really looking at, you're not looking at the infection, you're looking through the lens of that body's immune system, right, to see what antibodies you are making, so what infections your body thinks are the threat. Antigen testing is something that we have moved to, and we pair both together. So antigen is a little bit different. It is really when you're seeing your lymphocytes, T cells, presenting the antigen. Okay, you hang on. I can already feel all of you guys like, what the heck does that mean? Just hang tight. It can mean something like this. It means that, remember, the antibody is like a Y-shaped thing that's supposed to bind to the antigen, right? And that starts telling the body, hey, I've got the prisoner here in my hand, the bad guy. He really is here. The bad guy really is here. Let's go after him. And so that antigen antibody binding is essential. Just because you've got antibodies doesn't mean that there is antigen. Again, there can be antibody confusion, and with enough chemicals and enough infections, we routinely see that. So that's to say, if somebody started out with motor neuron damage because of lots of chemicals, and after this, we will go into pesticides, or they had lots of infections, and that was the cause. Over time, that picture kind of expands, not just to the cause, living or non-living neurotoxins, infections, or chemicals, but a disrupted immune system that becomes part of the big picture, which is motor neuron damage. And so how do you want to separate autoimmune confusion, right, from lots of chemicals, lots of infections, from what you're actually fighting? And so we will use antibodies to kind of get a sense of what the body is on high alert and reacting to, but we will also use antigen, especially in herpes viruses, and we will count those levels. Again, the presenting T cells in order to see the size of the enemy, right? The amount of the enemy or the reaction of the body to try and defend against that enemy. So we added that not too long ago, and I would tell you, it really has made things a lot clearer for us as far as prioritizing. So going back to the idea that an overwhelming majority of humans around the world have herpetic, so herpes viruses. The question, if you're testing yourself or if you're a clinical expert and you're testing somebody and you see, for example, somebody has the history of Epstein-Barr, cytomegalo, herpes simplex 2, herpes simplex 1, where do you want to start? We know in motor neuron disease, because it is progressive, we need to be able to pinpoint very quickly the top priority. And so if antibodies gives us the sense of what is the body on high alert about, then the antigen approach, and it's normally an antigen spot test is what it's called, that antigen test starts to really prioritize. How many of those antigens are you actually seeing? So if, for example, the range is do not be above a 4. So below a 4 is a body that isn't seeing that infection as a threat. And you are somebody that has 150, right? That becomes the top target. And if the second infection by comparison is only 50, right? It gives us a guide. And so now moving forward, it will give you a guide of how to prioritize these herpetics. Always on our side, if there are master infections, so in this case, we're talking about Lyme, because typically somebody isn't going to come here with active COVID. But if it's a master infection, so again, it's going to disrupt the immune system, we will always treat that first. We will look to address that first. Otherwise, that big infection, by damaging, distracting, destroying the immune system, will continue to provide an easy way for the opportunistic infections, mycoplasma, herpes viruses, Coxsackie, toxoplasma. The big infection will provide enough cover for those smaller infections to hide out. So from an order point of view, just summarizing, we'll go after master infections first. We will then prioritize the opportunistic infections. We now look at the antigen or the T cell presenting antigen load. It's a horrible explanation, but in order to get that priority, Terazosin or Terazosin, however you'd like to pronounce it, let's talk about it because it fits into this same category. So Terazosin or Terazosin, it is a medication. It's a well-known medication for blood pressure and to a totally different indication for prostate enlargement. It has been around. I should have looked up a date before I got on, but I didn't. It's been around for a long time. And it's just not a common medication to lower blood pressure any longer because there are better options oftentimes for blood pressure lowering. Here is something that's interesting. So we've been using it for a period of time. I decided to discuss it today because we've got a lot of people that are looking to have it added. And the question is for us, right? When do we add Terazosin on board? And the answer is specifically, it reduces the stress granule formation. So that's a response to infections. Bodies are making stress granules in response to infections. Okay. It can make them toxins, but it's a defense against infections. And it influences the TDP43 aggregation. Remember, that's the hallmark of this disease, right? Misfolded transcription protein preventing neurons from working properly. And so the question is, could stress granule formation, right, a body's defense against infections, be better controlled? And would that downstream then influence the amount of TDP43 misfolded, right? The misfolded transcription factor and how it's clumping together and preventing proper neuron firing. It looks very effective at doing that. You're looking right below at the Edinburgh Research Explorer that's describing the pathway to kinase 1 and how this medication can improve motor neuron phenotypes, so all versions of motor neuron in multiple models of ALS. The dosing is between 1 and 10 milligrams. You're going to want to have somebody take a look at this with you. And the reason, you don't want to decrease your blood pressure to a point where you're going to get weak or start fainting or falling down. and between 1 and 10 milligrams, that's a big window, does not change the fact that we're not looking to put it on board. We're looking to add it in cases where simultaneously we are treating infections, so we have control over stress granules. All right, so I think we covered everything at this point when it comes to infections. And if that's the case, I'm going to move over to serotonin and dopamine. Unlike infections, serotonin and dopamine is an area that I don't think have talked about before. And so now I'm going to switch to the slide deck and just kind of go through a couple of things. Let me preface by saying this. The reason we started looking at serotonin in motor neuron disease is because although we have seen routinely improvements, meaning functional gains, I struggle, and as a center, we struggle at speech improvements and swallowing. Right? And so the question then is, what is controlling speech and swallowing? Right? What is that related to very specifically? And because there have been a number of research studies proposed looking at serotonin and increasing serotonin, then for us, for the last maybe 3-4 months, it's become a big focus. And what I would tell you going into this, it's an area that we've been focusing on. And as a result, we're seeing improvements in that area, right, of serotonin involved functional changes. And so it made sense at this point to start at least sharing what's out there. Okay, number one. So I recognize again, I possibly make the ugliest slides available. It doesn't change. I think what we're looking at over here is some really, really important information. And so number one is this part in the center. Right? You are looking at a 2018 is describing in ALS, it has been hypothesized that serotonergic denervation, right? So serotonin related denervation or loss of neurons in an area leads to the loss of inhibitory control on glutamate release, resulting in glutamate-induced neurotoxicity in both lower and upper motor neurons. Here's what we're talking about. We know glutamine and glutamate toxicity is a hallmark of motor neuron disease, just like the misfolding of the transcription protein TDP43. We know medications like Riluzole are used to try and control that glutamine or glutamate toxicity. It is interesting, right, to see the role that serotonin is playing in that same area. And most people that we have seen, so if I had to categorize that, I would tell you it's got to be 90%, if not more, will describe that prior to the onset of motor neuron disease, prior to the onset of their first symptom, within 1 year, and on the outside of that, within 2 years, they had a very stressful, very difficult, very sad, or very anxiety-driven situation in their life, whether it was the loss of somebody that they loved, whether it was the loss of a job, whether it was stress in a relationship. And so I have been wondering for quite some time, what is the role of that episode of sadness or depression or anxiety? And why do we routinely see that happening prior to motor neuron symptoms? Well, within a year. On the outside, again, within 2 years, but it's almost always within a year. And for some people, it's shorter, within 2, 3, 4 months. And so we know serotonin plays a role. And to that point, and switching away from science and just talking about practical things that can be done, the best defense when it comes to controlling progression for motor neuron disease that we have found is not medicine, it is mindset and happiness. The best defense to protect motor neurons looks to be happiness, right? And so whether that is meditation and finding kind of a calm mind, whether that is laughter therapy, so you actually start laughing out loud, right? So you make yourself laugh even more, whether it's just watching something funny, whether it's having just a happy time with people that you love. But what we know is happiness seems to protect motor neurons, and the converse is true. Depression and anxiety look to cause progression. And now we know really what the role is. At the very bottom of the screen, platelet serotonin levels platelet serotonin levels predict survival in ALS. Now, that's a 2010 article, meaning this is not new. It's new. We as a center hadn't been focusing on it as far as therapeutically, what do we want to do about it? But this is not a new concept, right? We know the role that serotonin plays. Okay, and most recently, a grant that is in the process of being evaluated, linking not so much serotonin to ALS, but more specifically, serotonin to speech and swallowing in ALS. And ever since we as a center kind of got our arms around that whole construct, again, about 3 to 4 months, we have been very focused on that pathway, not just serotonin, but the relationship of dopamine to serotonin, therapies that we use typically as IVs to try and restore that balance. Okay, I'm going to say something that is very technical, just for the clinicians that are on the call, just to kind of get a sense. We are not trying to just put serotonin on board. That doesn't look to work. Although we do know that medications that increase serotonin, methylene blue, new Dexta, just as 2 examples, look to improve certain symptoms of motor neuron disease. New Dexta, which can increase serotonin, no surprise, it can also improve speech and swallowing. All right, here's the technical part. Remember, you're talking in serotonin about a 5-HTP pathway. Here's what that means. When you have the ingredients to make serotonin, serotonin is made primarily in the gut, but the part that you need in your brain is made in the brain, a very small percent, but based on the nutrients, the ingredients, the building blocks that you need. And with that in mind, I am putting together a serotonin-focused diet because I recognize that really is the next step for this. When the body has the ingredients, so if you don't have the ingredients, then you can't properly make serotonin, period. But if you do have the ingredients and the body does not want to be happy, let's say lots of inflammation, lots of stress, not getting a lot of sleep, the body is not going to be cooperating, right? It's not like you're going to make serotonin and you can't force a body to make it, or at least we have not found a way to do that. So instead, you want to recruit a body's willingness to make serotonin because we are now talking clinically about the kynurenine pathway, meaning if somebody is under stress, you are looking at a brain that is not going to be interested in making happiness. And so you are not going to take those ingredients and make happiness. You're not going to move down the 5-HTP pathway when you're looking at tryptophan. Instead, you are going to make quinolinic acid, which does not, of course, result in serotonin or happiness. It results in sadness, anxiety, and depression. So now, coming away from that, the clinical part, and coming back for all of us, what you're doing for happiness is more important than trying to force a brain just with medication to want to make serotonin. You are not, in our estimation as a center, going to overcome the intention of a body if lots of inflammation, not a lot of sleep, feeling aggravated all the time, having something that makes you angry, right? It is not a situation where you are just going to make serotonin, right? Because you're going to choose as a brain to stay in that kind of sad, anxious place. And so as a result, you will make quinolinic acid, right? And so the goal, going back to laughter therapy, doing things that you love. If in your life, you're not, or you haven't created boundaries to make sure that you're not feeling sad or bad, you need to do that, right? Because serotonin, you're looking at 3 different areas, 3 different links, but the one on top is the driver. Because again, we had folks where we saw improvements in speech and swallowing, but I could not nail down the reason. Looking at the data now, looking at the information now, it's because the serotonin pathway is so critical to that. And again, just using new Dexta as an example, directly in the world of motor neuron disease, commonly it's going to improve pseudobulbar or mood changes. That's what you would expect with serotonin. However, it's also modifying and oftentimes improving speech and swallowing. And you wouldn't expect that for serotonin, but now we know it to be something that is in the serotonin related area of motor neuron change. Okay, hang on. Let me see, guys. I can't get to my next screen. I've got him better next to me. Like, scroll down, but I can't. All right, thank you so much. Let's talk medications, right? And see again if we can't incorporate information plus active things that you can do on the medical side and active things that you can do on the lifestyle side. That's always my goal in calls. Ropinirole. So ropinirole is a drug that's been used in Parkinson's. It's been used in restless leg. It's been around for quite some time. It's been proven in the world of Parkinson's to be well tolerated and effective. Here's what we know as of last month. So ropinirole is a medication that's been on the radar for motor neuron disease for the last handful of years. It's not a new thing. What is new is the article and in the Journal of Stem Cell, right, that describes ropinirole coming through multiple studies, meaning the studies haven't been entirely completed, but looking at the preliminary information. So you can read it. It's a drug used to treat Parkinson's disease. It showed promise in delaying the progression of ALS, according to this study. And again, these findings came out last month. What you're looking below that, again, 2023, you're seeing ropinirole in the initial study in sporadic cases of ALS. What I would tell you is we have incorporated it. Let me tell you who we are using it with. That way, again, for anybody that's out there listening that's dealing with motor neuron, always the question is, do I start this? For anybody clinically that is treating motor neuron, same question, who's a good candidate? Let me stop and just say what I think everybody knows, but let me just make it clear. I am not a medical doctor, right? I'm not a clinician, right? My background is science. So I am not looking to give any kind of medical advice. So as my disclaimer, you're always going to check with your doctor, or if you're somebody that's here in this center, you are welcome to send us an email or call. If you have not been in here for a little bit of time, meaning that we'd already started using ropinirole, but you hadn't been here over the last month or two. So you can call them, we'll let you know. But we know with ropinirole, there are a handful of folks that have motor neuron disease. And it's not even a handful. I would tell you, if we had to guess it out, it's probably about 15 to about 18% of the folks that we see. There's a degree of rigidity and stiffness. And on the speech side, there is rigidity and stiffness as well, which I know is a funny thing to even say. In the world of rigidity and stiffness, the common term is bradykinesia, meaning you move, but you move slowly. I'll give you an example. Sometimes if you see neurology, they'll ask you to do finger tapping. It's not really common in motor neuron disease, but it's super common in Parkinson's. And so what everybody's looking for is, can you do this wide and fast? Stiffness is somebody that's like smaller, so it's diminutive, so it gets smaller over time, and it's really stiff and slow. And you can kind of get a sense of one side of the body where people can do this, and the other side where it's stiffer and slower, right? So you start getting an idea of which side of the brain and which areas in the midbrain may be affected. And so the reason I'm telling you that is that bradykinesia, or slowness and rigidity. Commonly, you can see it when people are walking. They're not really bending their knees as much. They're super slow in their walk. They may not have a lot of atrophy. So again, what we normally say, folks that have muscle loss, but in more of a uniform fashion. So not just an area in one arm that has a lot of atrophy, but kind of an all over body, almost equal loss, but not even a significant loss of muscle, an enormous amount of rigidity, and commonly a slowness to their speech, meaning they can pronounce most of their syllables and consonants. They don't have really visible atrophy on the lateral borders or the edges of the tongue. Instead, their speech is affected because it is slow. And that's our first group that we typically use Ropinirole for. And so if you were calling either neurology or your GP to get this prescribed, or again, if you come over here as a patient, you can just give us a call. It doesn't mean everybody is a good candidate, but if it's well tolerated and looks to be safe, and we know that model because it's been used in Parkinson's, then trying it to see feels reasonable. All right. Let's talk, and I know this feels like a weird shift to go from ropinirole over to pesticide exposures. Let me tell you kind of my thinking on how I built this slide deck. Parkinson's is an interesting condition because cases of Parkinson's can very definitely be attributed to pesticides. There are infections that are linked to Parkinson's, but pesticides are front and center. And we see pesticide exposure. We routinely test for those chemicals. There are certain pesticides that we're looking for. We see levels oftentimes in the folks that we work with that have motor neuron disease that are through the roof. I'm not sure if it's because the exposure in those individuals is so significant, or more likely, they are poor detoxifiers down certain pathways. It's the reason on our side, we will normally look to get testing on detoxification genetics. It's not, are you coming in contact with this stuff? It is, can you metabolize it and safely remove it? Because Parkinson's, many cases, an overwhelming number of cases, have an associated link to pesticide. So much so, there are multiple class action lawsuits, right, in cohorts of individuals with Parkinson's as a result of exposures or links to pesticide. It brings up the question of whether or not ALS has a similar exposure risk. And so you are looking at a 2021, just looking at pesticide exposure linked to ALS. Here you are seeing glyphosate and permethrin. So permethrin is a material that's used commonly to prevent ticks. Initially, when we saw a lot of tick-borne infections, the look on it that I had, funny statement, is that tick-borne infections have a link to motor neuron disease. We know that there is a link. However, what we also know is tick sprays, right? Permethrin in particular is associated with motor neuron disease. And I'll put a video out sometime this week. What happened was Susan is somebody that had a tick bite, thought the tick bite led to motor neuron disease, which occurred a couple months later, right after that tick bite. But what really happened was her husband sprayed permethrin on the soil. She went out to plant bulbs twice. Now, let me say this differently. She went out to plant bulbs. She got bit by a tick. He resprayed a second time. Her exposure was very substantial as a result. Remember, bare hands and sitting in bare skin, just wearing shorts, after permethrin was sprayed on the ground twice and developing motor neuron disease. Now, it doesn't mean permethrin caused motor neuron disease, but you are looking here at a very, very clear link. A tick bite on top of that, we start putting kind of a picture together. The reason I am showing you and highlighting glyphosate or Roundup as well, I'm now going to show you the link over there. So first, permethrin, and going back to dopamine and serotonin, we've spoken about serotonin and its impact, not just in motor neuron disease, but in speech and swallowing in particular. Dopamine is very, very critical because dopamine neurons can have serotonin receptors. Dopamine and serotonin play in a specific ratio. And so the fact that we are looking at permethrin as the link before this one, showing the association with ALS, and then this screenshot over here, just looking at its role in serotonin and dopamine. Now, thinking back to the previous slides, serotonin dysfunction, speech and swallowing. The question now is what's causing some of the serotonin dysfunction? And so I will move us to a point in this slide deck where we start talking about foods and controlling pesticide, because that's going to be an important next step. But I am hoping to get through it soon enough to be able to answer questions as well. That's always my hope, and I seem to always run long. So again, what you're seeing over here is permethrin. When you see Susan's video, one of the things that she found, she's an RN, a nurse, and a researcher. She has postulated a link. So permethrin is a pesticide that looks to be widely used in the military and sprayed on military uniforms to reduce the likelihood of tick bites. And so the question is, are we looking at a link between a specific pesticide and a cohort of people, military, that are at higher risk? So again, you're just hearing me kind of think through. So as we get more data and it becomes clearer, we will circle back and discuss our findings on it. So right now, it's just a hypothesis, but it looks to be a strong working hypothesis. All right. Right below this, again, you're seeing in ugly slide format, 3 different articles. So the question is, what do we think about pesticide and ALS? Which pesticides and ALS? And so you're just looking at a screenshot. If that's the search, right? Pesticide and ALS, commonly used neurotoxic pesticide exposure increases. And you can actually see right down here, significantly increases ALS. You are seeing glyphosate, or Roundup, which we routinely look at over here and find in people that we're treating for motor neuron disease. Below that, pesticides applied to crops and ALS. That's where you can see permethrin. That's why I'm stacking them like this. And then pesticides linked to motor neuron disease and showing both, right? There's glyphosate or Roundup and permethrin. So one actionable item is to make sure you are not coming in contact with pesticides. And oftentimes we will run a screen for pesticides and then run it again 3 months later. What we're looking to do is see if the changes that have been made, where you're sourcing your produce, how you're cleaning your food, how you're cooking that produce, so fruits and vegetables, whether or not it is decreasing the exposure or not, right? So again, normally for us on the chemical side, we will test them to get a sense of what's going on, and then we will retest in about 3 months to see if lifestyle modifications are in fact reducing pesticide. We have had folks before where they come in, we treat, we can see improvements, they go home and then they worsen again. On our side, always one of the questions, it could be for any number of reasons, but just to let you know, some of the things that become really important to us is there mold in the home. The things that person is coming in contact with, the water, for example, is it water that is toxic, either with pesticide, with chlorine, fluorine, or heavy metals? And we'll oftentimes ask people to get their water tested. Or are they eating in a way that they think is healthy, but in fact, it's not healthy? And so again, one of the focuses that we have when people come on over here, educate on mindset, going back to serotonin and dopamine, education on what to eat, and also sourcing healthy foods. You are looking at, it's kind of a funny chart. I recognize that this is a direct look at Crohn's and ulcerative colitis. So those are gastrointestinal problems. Let me tell you the rationale. Butyrate is commonly low in a significant number of people that have motor neuron disease. Here's how we know it. Because Relivrio, or sodium phenylbutyrate, is now an FDA-approved drug. Why would an individual with ALS have low levels of butyrate? So let me switch this around. Why aren't you making that fat in the intestines, right? So butyrate is something that humans routinely make in the colon. It is when you eat certain fibers, and then those fibers are converted by microflora in the gut to make the short chain fatty acid butyrate. Why would butyrate all of a sudden decrease? Why would you need to supplement butyrate in the intestines? So again, we know that the intestines are affected because we know butyrate levels are low, because there is a medication that is now FDA approved for people that have motor neuron disease. So now you can see why I'm looking at a graph that is assessing intestinal inflammation. So inflammation specifically in the colon, both in Crohn's disease and as ulcerative colitis. I would actually have cited the source, but this was on ResearchGate. And because I couldn't find the source, I'm just going to reference instead the link in case anybody wants it. Here's what you are seeing. 1990, right until the time that this study was completed, which is 2010. And you're seeing the amount of inflammatory bowel disease in purple mirroring the increase in the amount of glyphosate that's used. Now, interestingly, I couldn't find an exact chart, but the charts that I did look at for motor neuron disease look to also mimic this same trend. Okay, let me take us back for a minute. What we're talking about is serotonin and dopamine, right? We know that those two neurotransmitters are important for ALS, right? The platelet levels that have been identified in 2010 relating to progression in individuals with ALS, right? We know the link for serotonin with speech and swallowing that's being evaluated. We know the role that permethrin and glyphosate can play in ALS. Right? And now what we're looking at is inflammatory bowel disease. Remember, butyrate is made primarily in the colon, and we're looking at glyphosate and its role in damaging the colon. And so I'm not trying to take this whole picture and stick it on to pesticides or glyphosate. We started out by talking about infections. This is just kind of a general conversation of things that you're looking for. What we find, it's not one thing, it's the combination. And as soon as you can start identifying what that combination of neurotoxins is being made up from, then you can kind of start reverse engineering your way back out of it. So we find infections and chemicals to be primary, front and center when it comes to motor neuron damage. And again, one of the pathways looks to be serotonin and dopamine. And so now just kind of looking through pesticides, one more article, just kind of talking about the same. And the reason I put this below that other chart, this 2021, so imagine 2021, explaining glyphosate and paraquat. I know lots of folks that have come here, especially farmers, right, have had a lot of exposure with paraquat, and you're looking at the relationship, the known association with ALS. Okay, here is a tip on how to get better control of exposures if you are having any fruits and vegetables. Now here, I'm going to take a step back. I'm going to make a dietary recommendation. Now, I'm going to, again, put a disclaimer out there. Not only am I not a nutritionist, but I am not a clinician. I'm a scientist. I'm going to make a recommendation, and my disclaimer is always check with your own doctor. All right, the long and short, what we know about cells. We know that they must go through glycolysis before fatty acid oxidation. Here's my point. Without any sugar at all, cells struggle to turn on glycolysis. And without glycolysis, fatty oxidation is hard to start. It's no different than a starter in the car. I know everybody now has the button, but before, when you had the key, if you don't turn the key, right, if you don't turn the starter, you're not going to get the engine to turn on, even if you've got gasoline. This is kind of the same situation. The starter is glycolysis, meaning it is rooted in sugar. So much so that if you do not eat sugar, you can convert things, serine as an amino acid, into sugar, right? So bodies can make their own sugar if sugar is not in the diet. The diet that we like, the majority, so about 40 to 45% lean, clean animal protein, meaning very low fat animal protein. Filet mignon, 99% fat free as far as ground beef, white meat over dark meat. Okay. The other 40 to 45% of a plate should be healthy plant-based fats. Now, going back to animal, always grass-fed, grass-finished. On the healthy fats, that makes up the other half of the plate. So now what you have in your mind is a plate that's divided almost in half, but this tiny piece of that pie chart that is not included. We like very complex carbohydrates. So we'll always recommend people look at a glycemic index, download a glycemic index on your phone, on your laptop, and then pick things that are the very, very lowest. And so typically each meal will include 40 to 45% lean animal protein, 40 to 45% healthy plant-based fats, typically omega-3 and 9, and motor neurons prefer what's referred to as DHA, right? So DHA by comparison to EPA. It's more than I think what we've got time to go into right now, but at least it gives you kind of a Google search that you can do after this. And remember, you need glycolysis in the cell, so you are still going to need that very small kind of sliver. And that for us is always about rainbow diet, right? Most amount of colors, lowest amount of sugar, slowest releasing sugar. Okay, so now taking that into consideration and looking at this article, they are talking about whatever that small piece of the pie is, right? So 5 to 10% of each meal being very complex carbohydrates to provide the sugar for glycolysis, but in a very slow releasing format. The question is, how do you ensure that those things are pesticide free or lowest amount of pesticides? So you're looking at an article that just came out last year, 2022, boiling, blanching, and stir frying vegetables would markedly reduce, and the rest of the explanation is pesticide in those vegetables. And so on this chart, which was taken from that article, left side, they're describing the pesticides that are on those vegetables. And then on the far right side, they're describing what percentage of the pesticide was reduced, in this case, by boiling them. I'm not making a suggestion that you boil the life out of things so that they don't have any more vitamins. So be careful, right? Don't just boil. At the same time, you want to always clean things. We like Arm & Hammer baking soda, right? It's looks to be a safe and effective way, sodium bicarb, to reduce pesticide by soaking fruits and vegetables. But this article really describing outside of that to either boil, blanch, or stir fry in order to markedly reduce pesticide becomes important as well. Okay, the other thing that you may want to Google, so you're just seeing my Google search over here, is how do you pick things that are the lowest in pesticide? Normally there's a dirty dozen list. The dirty dozen list is going to show you the fruits and vegetables that are the highest in pesticide, normally because they are thin-skinned. So oftentimes they are some of the lowest glycemic index, meaning the most desirable: apples, pears, berries. But because their skin is so thin, pesticide goes right to the skin and into the fleshy part that we're going to eat. By comparison, a thick-skinned, and you're seeing avocados being one of the healthier fruits when it comes to low pesticide. Again, it's got a skin that's hard for pesticide to get through. Bananas are on that list. However, at this center, we are not fans of bananas because the glycemic index is too high. And so again, avocado as a fruit is something that we oftentimes recommend because it is high in healthy fats and is oftentimes something that doesn't have a lot of pesticide. But there are a number of other fruits and vegetables that fall into that category as well. So even organic fruits and vegetables are oftentimes, when tested, high in pesticides. Oftentimes pesticides are aerosolized. That's the most common way to get them out there, right? Spraying them on things. And once it's in the air or it's in the water, and then there's runoff to a neighboring farm. And even if that neighboring farm is organic, still there can be a lot of pesticide exposure. And so for that reason, choosing foods that are known to be low in pesticide becomes important. If you are a patient in the center and we need to talk about either Ropinirole or Terazosin, then let us know. If you're somebody that's looking to get more information about the center or thinking about coming on over, this is how you reach us. Let me go ahead over to the chat and to Q&A. And for this, let me throw on some glasses. All right, so first of all, I've got Greg. Your question, does your clinic test for all forms of herpes and zoster? We do. And so again, keep in mind the role that these infections are playing is very different. Our understanding of them is very different over the last couple of years with COVID. And really seeing the rise in neurodegenerative diseases after COVID is impressive. At first, when I looked at it, it felt like COVID was the cause. It's not to say COVID is not related or that COVID can't impact brain and neuron health. However, the bigger issue looks to be COVID and its ability to destroy T cells and allow opportunistics to reactivate more frequently. And so what it looked like a couple of years ago, herpes viruses reactivate rarely. What we know now, when I say we, what's been published, they reactivate routinely, especially when T cells have been disabled by an infection like COVID. And from that point forward, the opportunistic infections, herpes being in that list because so many people have herpes viruses, start reactivating frequently. And again, it looks to be the neuroinflammation that is associated with those reactivations that ultimately leads to neurodegeneration and neurodegenerative diseases, or at least in part. What we know on an antiviral standpoint, so we don't typically in our treatment use basic antivirals. We don't find it to be effective. Instead, we have a number of things that we'll use to improve the immune system's awareness of the infections. And the reason is antivirals, while they can impact and decrease the replication of these infections, they do not look to have a strong ability to prevent reactivation. So in other words, you can bring down the number, the viral load, and then people stop using those antivirals. The load just comes right back up again, and you keep reactivating. And there are plenty of people that can relate to that. They're the folks that, for example, might have a cold sore, and they're routinely on acyclovir or valacyclovir. And in spite of being on that routinely, the second that they stop, they'll get cold sores again, or they'll get genital sores again. So again, what we know is the real challenge of this is not using an antiviral to decrease the replication, but rather an immune strategy to be able to control reactivation, because we know the reactivations are really linked to a T cell change that has oftentimes been caused by an infection, but T cell damage and decreasing T cells can be caused by all kinds of other things, including chemical exposure. So that becomes important. So Greg, yeah, for us, we're always going to test tick-borne infections. We're going to look for co-infections. The question is there a master infection in play? We're going to look for other things that are associated with motor neuron disease. So that's mycoplasma. We're going to look for toxoplasma and parvo-19 virus. And then we're going to do a very comprehensive search as far as herpetics. We are going to look not just at antibody load, but if we expect herpetics are playing a role, then we are going to look at antigen as well. Keep in mind, if we have somebody, and this does not look to be immune mediated or infection related, if it's just chemical, then for us, that's not as big a priority, right? So we put that on the back burner to figure out the chemicals and prioritize non-living neurotoxins first. And we have plenty of people that are here with improvement that we have never treated any infections. And Susan, so we were talking about permethrin. She has had improvements, and we did a video today because she's able to move her legs now, but she hadn't been. We have not treated infections in her at all, right? She is chemical related. So you have to kind of figure out, or at least we could help you figure out, are you more chemically mediated? Are you more infection mediated? Are you more autoimmune mediated? Or are you the combination? And the key is, what's the starting point, right? Knowing progression and the fact that this is a progressive disease. The key from our standpoint is not the treatment, it's the strategy. And that strategy is unique to each person. There isn't a protocol or a one size fits all or an ALS strategy. It is that individual, right? Do they have genetics, detoxification genetics, right? So how their liver removes things like chemicals. Do they have detoxification genetics that will put them at higher risk of being poisoned and having these pesticides that work as neurotoxins become more neurotoxic? Have they had diesel exposure, but a 1B1 mutation is preventing proper removal of diesel? Have they had diesel, so you're going to bind those petrochemicals to an aryl hydrocarbon receptor? The problem, that is the antiviral receptor launching T cells. So I don't mean to throw a bunch of things out there, but just know, even though we test for those things, I think your real question for me is, are you the person that would need to be tested for them? So the reason this is, I think, useful as a conversation, both for people that have this condition, motor neuron damage, and the resulting motor neuron disease, or for people that are treating it, the real question is, what is your strategy? What you're looking for, in my estimation, it's not a bunch of widgets or band-aids, not a bunch of medicine. It's a medical strategist and something that fits from your exposures as a therapy approach, right? So Greg, so you just sent another one. So the first question was Greg's. This question is Greg's. You need direction and advice on taking Riluzole 50 milligrams. You've been on it for several months now, about to add Radicava. Thoughts and safety. All right. So I give you my same disclaimer, right? I am not a medical doctor, so I am the wrong person to ask this. What I would tell you is looking at the FDA findings, meaning, and I'm not trying to be cryptic. I'm happy to answer it, just not specifically, I don't know, in the way that you're looking for. I mean, here's what we know. Riluzole has been around for a long time. There has been very, very little impact on this disease, the survival rate of this disease, or medical management of this disease. Okay. The idea that the medications that are available can extend lifespan for very short windows. It's been estimated to be 3 to 6 months. On our side, we don't find that to be adequate. I would tell you about half the neurologists that we have spoken to believe that Riluzole, Radicava should be used because they're on label. About the other 50% will actually tell their patients, don't use these medications. They don't have any value. What we are seeing potentially in the literature at this point is combinations of Riluzole, possibly with butyrate or other medications. Valproic acid has been thrown around as well. Lithium too, in combination with Riluzole. So what we know is, if Riluzole was a good solution, and we know it's been around for a while, then there would certainly be better disease control or disease management. And so I would tell you, I take the FDA labeling at its word. It can extend lifespan with a very, very short period of time. As a center, we just don't find it to be adequate. And so we are not pinning our hopes or wrapping our treatment strategies around Riluzole. Okay. So again, I would tell you, it's a better question for an MD. But on our side as a center, it is not something that we routinely incorporate. When somebody comes here and they're on those medications, we do not make the recommendation that they stop them. If you are somebody that wants to take that medication, you're comfortable taking that medication, or your physician has asked you to stay on it, we don't have a problem unless we see elevated liver enzymes. If we do, and somebody is on Riluzole, we will commonly have them stop for 3 to 5 days. We will measure liver enzymes again. If we see liver enzymes have come back within range, we will advise you of that fact, and we will normally send something back to your prescriber to let them know that our recommendation would be to come back off that medication. Remember, stay tuned, because the question isn't, does Riluzole work? I think for most people, their thinking scientifically and medically is that it doesn't. The question is, could it in combination? And that's what's unclear at this point. Okay, Dane, is there any new information regarding dysautonomia and tissue perfusion issues? Would this be related to dopamine disruption, perhaps? It's a complicated question. Hypoperfusion, so low oxygenation, low blood supply, is a common component of motor neuron disease. It can be measured in several ways. VEGF, so vascular endothelial growth factor, is probably one of my preferences as far as how to see it on a lab. Using ways to increase perfusion. So, for example, methylene blue, it can increase perfusion. We have not found that to be the case with oral use of methylene blue, but we have with IV. We know, or it is known, that hypoperfusion, so poor oxygenation in the tissue, again, is not uncommon in motor neuron disease. The question is, are you trying to correct the hypoperfusion just by putting something on board to increase perfusion or blood supply and oxygenation in the area? Or are you trying to figure out what's causing the hypoperfusion? So on our side, we're not so much about just treating the decreased oxygenation or blood flow to certain tissues in individuals with motor neuron disease. Instead, we're looking for the cause of that hypoperfusion, and it is commonly infections, right, that decrease oxygenation in order to create an environment for themselves to grow. And so always for us, the question is cause or effect. If it's the effect, we may look at it, but it's not a priority for us at the start to treat it. And so the dysautonomia and tissue perfusion, again, the question is what is causing it? And I think that's probably the direction to go in. To your point, is dopamine disruption in that mix? Still, the question is, what is controlling dopamine? We know, going back to dopamine in the midbrain, so if we just look at Parkinson's as a model, not ALS, if we were to look at Parkinson's, we know that the substantia nigra, which is making or holding the dopamine cells, right, that's in the basal ganglia, just below the thalamus. We know that that is oftentimes damaged by pesticides. And as a result, a neighboring nuclei, the subthalamic nucleus, is not properly inhibited. My point in saying that, because we know that model in Parkinson's, can we kind of look at that model and use it in motor neuron disease as well? That is the dopamine anatomical or physiologic model in Parkinson's, oftentimes set in motion through pesticides and as well infections. So yeah, I mean, dopamine, when it's decreasing, will very definitely cause that rigidity or bradykinesia, along with a number of other symptoms. And so dopamine plays a role, but for me, in the perfusion side of things, I look in a different direction. Okay, Alex, before traveling to Miami, is it worth doing any testing remotely from home? Or is there anything else we can do? There is no one size fits all. And the only reason I tell you that, we will typically do a Zoom call before anybody comes. On that Zoom call, we are looking to strategize. So I'm typically the one that you'll be talking to over there. It's not a clinical call, it is a strategy call. The question is, what test do you need? I'll tell you what I see routinely. I see a lot of people running a lot of tests that ultimately do not translate into any type of therapy. And in spite of a lot of people having a lot of tests, I don't see a therapeutic component as part of the next steps. On our side, we are not looking to run a bunch of tests. We are looking to get clear on certain pieces of information. So let's say the suspected theory was chemical exposure. Which chemicals and what chemical panel do we need? Let's say the suspected theory is herpetics. Because of the location, the one-sided changes. So herpetics can often, unlike my earlier discussion of dopamine, where you're kind of seeing a whole body and almost an equal amount of atrophy or minimal atrophy. By comparison with herpetics, we are seeing a lot of one-sided changes. So, for example, somebody that has one arm that has significant amount of atrophy, or both arms, but commonly it might be left arm, left leg, right? Because we know that herpetic is on the left side when we're talking about dorsal root ganglion. So just pulling back for a minute, let me just tell you, it's not a one size fits all, but I wish it was. If you're just looking to test for the sake of it, then I always like infections, chemicals. I like looking at nutrition to get a sense of where gut function is. I like immune testing. So we're typically looking at those. It doesn't change the fact I would schedule. So this is not some kind of shameless plug to get a bunch of people to schedule. All I'm saying is you're probably going to need a strategist. I would talk to somebody, or I'd call over here to get a sense of what the next steps would be or what the testing should be. I don't really think you want to run a lot of very expensive testing and then wait for those tests to try and determine why you have motor neuron disease. You want a strategist that's ordering tests not to determine the cause, but to confirm the hypothesis and then delineate which pesticide, right? Is it chlorinated? Is it a phosphorylated? What exactly are you trying to treat? And so even if you got a chemical panel, even if you ran one, but you don't have the right chemicals, are you looking at things like perchlorates? Are you looking at pesticides that are more atrazine, for example? Are you looking at something that's not even in that category? Are you looking at a solvent related issue? So methyl hippuric acid. So you want somebody that can kind of look at your history, get a better understanding of what you need, and then treat from that standpoint. Okay. Oh, Romulo. Hi, Romulo. Hi, Sue. It's great to see you. You stopped Riluzole and Radicava since 2 years ago, and you're still very stable. Romulo, I don't want to go too deep into yours unless you tell me that I can. But yeah, we figured out a handful of things that became really, really critical at the beginning, and took something that I think was more rapidly progressing and kind of moved it into a very different personality. And so I agree. I remember during that time, you can. All right. Hey, thanks so much. So Romulo, there was kind of an interesting, hang on, I'm gonna take us off the screen share. I just realized that we're stuck on that screen. I'm just gonna put us over here. And let me just close out, hang on, this screen. Okay, so Romulo, what happened, you came in, an expression that I commonly use in the folks that we work with that have motor neuron disease, you know what you know. If you think that something either caused this or is triggering progression or is related to your symptoms, chances are you're right. And no matter how many people tell you that you're not, chances are you're right. So Romulo, I remember we were sitting in the same room, in fact, and you said my feet became purplish colored, so purpurea. And then I developed motor neuron involvement shortly after. And on times where I'm relapsing, my feet become purple. And that felt more in the world of a toxoplasma and a sock and glove picture, meaning oftentimes neutrophils as a result of an infection. So it's a group of white cells that are causing that purple color. And what I would tell you guys, it wasn't red. It's not like red skin. It looks like a purple color. So I remember it was about 2 years ago. Romulo said that. He shows me his feet. And I remember saying to you, look, I don't know what this is, but I'm clear on the fact that as a center, we had better figure it out. We had better get clear on what it is and what we want to do about treating it, and then put that into place. It is true. During that time, you had gotten, I don't recall if it was the COVID as an infection or the COVID vaccine, but it made the whole thing worse because imagine it's a virus added into a picture of neutrophils that are already dysregulating because of another infection. And so we looked to treat that, and did. And over the last 2 years, I agree, you have largely been stable. And so thanks for bringing that up. I think it's a really important point. Let me see on the chat, the Q&A, if I've got anything else. Romulo, if there's anything else, to your point about the vaccine. So Romulo just added one more thing. Yeah, I mean, the vaccine moved you from stability into just motor neuron progressing. I would tell you guys, I think this is a relapsing remitting disease. I think most people are in chronic relapse, so they're always progressing. I think what we're seeing is people that are being moved into remission. I don't think this is a cure, but I think it is a way to stabilize things. And we've seen it for like extended periods of time. But to your point, Romulo, could you move from remission in motor neuron back to relapse with a trigger? And could a trigger be a vaccination? Certainly in your case, that is what happened. Not to go down the road of a vaccination conversation, but rather just to discuss COVID vaccinations and their role in potentially reactivating Epstein-Barr. That was fairly well researched from a group of transplant surgeons, So for people that transplant solid organs, so primarily kidneys, liver, they need to ensure that people are not having an outbreak of a herpes virus before they do that transplant. And so they are routinely testing their transplant patients to make sure they do not have a herpes virus. Transplant teams in general required a COVID vaccine. And then at least one transplant team reported on the fact that what they saw immediately after vaccination and for up to 10 months after was the immediate, meaning within 1 week of the vaccine, reactivation of Epstein-Barr, right? So I'm not making any claims or any statements about vaccines and what they do. I'm just telling you what was reported by that group. And then Romolo, to your point, you essentially moved disease that at that time, it was like a December, it wasn't perfectly controlled, but it was relatively controlled and progression was manageable. After the vaccination, it became wildly uncontrolled. And so what we saw was these opportunistic infections. So going back to the first part of this conversation of infections and triggers for those infections and master infections and how they relate, wildly moved you into aggressive progression. And I remember you were not able to easily stand or walk at that point. Your voice had worsened substantially. And then we got control of a handful of things, again, going down that path and T cells. And I believe you've been pretty stable since. So that makes my heart feel happy. And it's probably a good time to end this conversation. All right. So I don't have any more questions anyhow. Let everybody go, because I know we're about 20 minutes over at this point. I want to thank you guys for joining. What I would tell you is, if you have suggestions of things that you want to hear about, if you want to talk about, let me know. I always think about doing this in the form of an open question and answer. It's just a little bit tough to moderate. I have thought about everybody submitting questions ahead of time and then going through those questions. When I asked the folks that were here this morning what they wanted to talk about, it was more diet related. So I know we've got to address that as well. Again, if there's anything else that you want to talk about, just know as a center, we really are here for you guys, meaning whatever you want to talk about. If it's something that for me, I know about, then I'm happy to. All right. And so with that, everybody have a great day, and I will look forward to seeing you again.